So I just wanted to give a brief update on some of the advances in Parkinson's disease, not only medications, which is why I've indicated therapeutics here rather than just medications, because it's not only, fortunately in Parkinson's we have options that are medications you take by mouth. There are also options that are surgical, including brain surgery options, and then a newer one that requires a pump that you wear to actually give administration of medication right into the gut. So the point is to be somewhat comprehensive, but to focus on what are actually real developments, not theoretical developments. Those are important too, but this is stuff that's actually is or imminently available. So it's important to emphasize, I think, that already there are over 15 different movement medications alone in Parkinson's, meaning Parkinson's affects lots of different things in addition to movement, what are called non-motor features of the disease. But just the movements alone, the tremor, the stiffness, the slowness, the problems walking, we have over 15 different medication options already, and those are set to grow over the next 2 to 3 years to include a number of new classes of medication. And in addition, the non-motor medications are also actively growing. We'll talk about one of them that should be available hopefully later this year. And then there are some clinical trials that are just starting in Europe actually to try to actually slow the progression of the disease itself. So far all we have are medications that try to address the symptoms, and to varying degrees of success they can, but they don't stop the actual progression, the disease process that starts with an abnormal protein called synuclein. It damages cells, it spreads into other parts of the brain, and accumulates damage throughout the nervous system. We haven't been able to figure out how to stop that, and those types of clinical trials are now just being started. And so it's really an exciting time in Parkinson's, and the hope is that some of these things won't just affect Parkinson's, they'll affect other neurodegenerative diseases like Alzheimer's, frontotemporal dementia, because they all seem to follow similar paths. There are different proteins involved, different pathology, but the fundamental concept that you have a bad protein that then spreads its badness, so to speak, throughout the rest of the brain happens in all of these diseases. So if you can solve that problem in one, there's a good chance you can solve it in another. So we'll see. And so the keys here on the medication options, these are medications by mouth. There's a new psychiatric medication that we'll review. There's a new form of carbidopa levodopa that's a longer acting form that we'll review. And then there's a new medication for low blood pressure, a very common problem in Parkinson's where the blood pressure drops, especially when patients stand up and they can pass out or feel lightheaded or have some variation of that theme. It's very debilitating and very common, often underdiagnosed, and now there's a new way to try to address that. There are new and evolving surgical options. So deep brain stimulation is not new. It's actually the silver anniversary this year of DBS as an approved therapy for Parkinson's. But there are new techniques both with targeting the electrodes in the brain and then programming how we stimulate those electrodes. And then there's a new, as I mentioned or alluded to before, a new intestinal gel form of carbidopa levodopa that gets administered from a pump that you wear. So we'll talk about that. And then also there are a few more provider options for those of you who are tired of seeing me or want to see somebody else. That's fine. I won't take it personally. We're hiring some new folks, and I wanted to make sure you guys were aware of that. And then there's some new research options that are very exciting that we're going to be starting to pursue. So a lot going on. So from the medication options, there's a new medication called Placid. It's the trademark name. The generic name is pimavanserin. It's a very interesting medication that binds to serotonin receptors. You may be familiar with that term from antidepressants, which also target the serotonin system in the brain. This does so in a different way. It binds to very specific ones and actually acts in a new way. It binds it, and then it drops the level of activity of that receptor below where it normally is. So it doesn't block the receptor, it doesn't activate the receptor, it kind of gently decreases the baseline activity. And that results in clinical trials in the decrease of Parkinson's disease hallucinations and psychosis, where people get very agitated or have paranoia associated with their hallucinations. And it was quite effective in the clinical trials, and the nice thing about it is that it may have fewer side effects than currently available medications. So this is a common issue, particularly in advanced Parkinson patients or in patients that are older with Parkinson's, and sometimes in response to the medications that we actually use in Parkinson's. And to be able to have something new that doesn't hopefully doesn't have as many side effects as the currently available medications we use is going to be a big deal. Unfortunately, the FDA awaits a new drug application. There's a whole process that you have to go through in order to get your medication approved. They've completed most of those hurdles, they being the company, but there's one last hurdle to get through the FDA, and we expect that that'll occur probably by the end of this year. They're going to submit most likely in the summertime for this new drug application, and if and when the FDA approves that, which is really a final step, then that should become commercially available hopefully by the end of the year. So we'll keep an eye out for that. There's another new medication called RightRe. That's, again, the trademark name, the brand name. The generic name is carbidopa levodopa, as you all are familiar with. But what's interesting about this one is it's a capsule that has in it the immediate release form of carbidopa levodopa, like many of Parkinson patients are on. But it also has extended release beads inside the capsule. So you get the immediate release like you do with your regular carbidopa levodopa, but then there's an extended release form. And why that matters is that carbidopa and levodopa actually last a very short amount of time in the blood and therefore in the brain. Its effects only last about 2 to 4 hours. And that's a big problem because you have to take the medication, as many of you are aware, over and over and over. And so the reason this was designed was to see, is there a way you can take a medication that gives you that immediate bump and then keeps the level stable over a longer period of time, so you decrease the frequency that you need to take the medication, but also hopefully, and this is the part that isn't proven yet, decrease the problems that go along with taking the medication frequently. So if you take carbidopa levodopa, the levels go up and they go down, they go up and they go down. That process in and of itself causes problems like dyskinesias. You've seen Michael J. Fox moving around, and then wearing off, where the medication effect lasts a shorter and shorter and shorter period of time, so you take it more and more frequently. And so the hope is by doing this with the medication, getting it up and keeping it up, that will reduce the development of the dyskinesias and of the wearing off. That part isn't clear yet, but that it does do a good job of keeping the level stable is clear from the clinical trials. And so this is available now. It is commercially available. And the problem that I see with this medication, and this is my opinion of the interpretation of the clinical trial data, is that the impact was fairly modest. If you looked at how much a change there was in the amount of dyskinesia or how much a change there was in the amount of wearing off, it was statistically significant. But it wasn't that you're changing it from being wearing off for 5 hours to being no wearing off at all. It wasn't that big of an impact. But for some patients, we'll have to see if this may have a very significant impact. And that's the problem, is clinical trials are done in very, very tight ways, and you have very good control over everything. When you get out into the real world where people are also on all kinds of other meds, have other medical problems, how does this medication act? And we don't know that yet. So we'll have to see. This is something definitely to keep an eye on, and for some patients will probably be effective. And then again, if it becomes clear that this medication actually does reduce the development of the dyskinesias and the wearing off, that obviously will play a big role in potentially starting patients on this form of carbidopa levodopa rather than on a different one, but that's not clear yet. So another medication is called Northera. The generic name for that is Drakhsiddhappa. It's actually been available in Japan since 1989, and it just went through FDA approval more recently in the United States, and it's only available actually in Japan and the United States. And this is for that problem I mentioned earlier, where the blood pressure drops in Parkinson and other types of neurodegenerative disease patients. A very common problem, again, that we can make worse with the medications that we use for Parkinson's. And this is an interesting compound because it gets converted into norepinephrine, essentially adrenaline, in the body. And the reason that helps is because that actually raises the blood pressure, and it looks like in a manner that may be safer than currently available medications that raise blood pressure in Parkinson's and other conditions. So it may have fewer side effects. That's not clear yet from the way the clinical trials were done. So again, we have to see how that translates into the day-to-day real-world use of this medication. But the clinical trials did clearly demonstrate an improvement of about 10 points or so in the blood pressure at baseline, and a decrease in the amount of times that patients felt lightheaded when their blood pressure dropped. And so that can be very effective in Parkinson patients, and again, hopefully will have less in the way of side effects, including the blood pressure going too high when you lie down, which is a very common and potentially dangerous problem with medications that are currently available to try to raise blood pressure. So we'll have to see how that plays out. But this one is also available now and is being used in Parkinson patients. So we'll switch gears from pills to brain surgery. And so with DBS, as I mentioned earlier, there are new anatomic targeting techniques. So for a long time, there are a couple of areas in the brain that we tend to focus on with DBS. One called the globus pallidus and another called the subthalamic nucleus. And the reason we target those two areas is because when you provide electrical stimulation in a controlled fashion, you can change the way those areas fire the nerve cells, and how that nerve cell firing then translates into how those nerve cells interact with the other areas in movement-based networks in the brain. And so that's a very effective way of treating some Parkinson patients, not all. Only about 5% or so of all Parkinson patients end up being good DBS candidates. But for those patients, this can be a very effective therapy. But the problem is that you tend to stimulate areas that you don't want to. So if you put an electrode in the brain and then you start stimulating it, you have an area that's a sphere of electrical stimulation. Well, there's a lot of stuff in there you want to stimulate. There also is a lot of stuff in there you don't want to stimulate. So how do we do a better job of targeting just the areas that we want to stimulate without the areas that we don't? And that's a very active area that some progress is being made. And in addition, right now, the main way that most folks end up doing DBS is by doing it during awake surgery, where you're actually recording as you go with the electrode through the brain cells to get down to the part that you want at, which is actually pretty deep into the brain. You're recording all along that way to see, am I in the right spot? And now there are ways of doing it just relying on three-dimensional space. And so you can identify where the electrodes are through actually using MRI in the operating room, and just by using that, identify where you ultimately want to be. And that potentially could shorten the time of surgery and shorten some of the other things that go along with it to make it a more efficient surgery. So that's an exciting development on the anatomy side. And then on the stimulation side, there are new ways of being able to deliver the electricity. So now, instead of just giving a sphere of electricity, you can actually start to modify how that electrical field looks depending on how you use the electrode that's left in the brain. And so the reason that's helpful, again, is you want to target the area you want to with stimulation, but avoid the areas you don't want to. So if you could modify the way the electrical field actually looks in space, you can do a better job of that. And so that's being done now as well. Still a little bit early for clinical use now, but that technology isn't far away. What is available now is a way of having the two electrodes, because we tend to put one electrode on each side of the brain, to have them interact and fire in a very particular way relating to one another that also tends to minimize side effects with the use of DBS, which can be significant. And it does, again, basically a gentler form of stimulation that you can control with a finer tuned knob than just turning something on or off, basically. And so that's another exciting development on the electrical stimulation side. And then there's also a lot of, yes, please.
Can you talk about what this does to symptoms as opposed to what you're doing now?
Yeah, so right. So what this potentially would do is really limit the side effects associated with the stimulation. So it allows us to do a better job of just targeting the areas of the brain that we want, so we can deliver the appropriate amount of electricity to that part of the brain to improve its function, but without simultaneously delivering electricity to parts around that area that we don't want to stimulate, because that really ends up limiting what we can do in a number of patients. If you're stimulating the area you want to, that's great. But if that's at the expense of those people not being able to speak well, or be able to swallow well, or not be able to think well, that's not great. And so this provides an opportunity to finer tune the delivery of the electricity to get the symptom benefit, but without a lot of the side effects. That's the main goal of this. Does that answer that question?
What kind of precision do you need in order to place these electrodes? Are we talking about microns or?
Right, so the question is how precise do you need to be in order to place the electrodes? The order of precision right now is on the order of millimeters. The more precise it is, the better, but the stimulation is much larger than microns. So you have to keep in mind when you generate that electrical field, it's a pretty big area, big in neuroanatomic terms. So it doesn't really matter if you're off that much. And the nice thing about a DBS electrode is it has 4 different contacts that spread over an area of about 3 millimeters or so. So even if you're too deep or too shallow, you can still typically accommodate for that by carefully programming, so you use the right combination of contacts to get the area that you want. So there's some imprecision that's allowed by being built into the way the technology is developed. And then on the possible earlier treatment window, this is something that I wanted to bring up because I think there's some misinformation about this right now. There have been some intriguing studies that have tried to look at DBS earlier in Parkinson's disease duration. So typically we have considered the ideal DBS patient someone who has on average somewhere between 7 to 10 years of symptoms, who doesn't have a lot of problems with thinking and some other issues like mood and behavior, and that has the expected side effects of levodopa, the dyskinesias and the wearing off that I mentioned before. There have been some studies more recently. They said, well, what if we do this earlier? Instead of waiting 7 to 10 years, is there a benefit to doing it maybe at 3 to 5 years? And there's a suggestion from some of that data that the answer may be yes, but that's not at all clear. So there's been a lot of talk that, oh, you need to do DBS earlier because you miss the window if you do it later. That's completely wrong. And I want to make sure that everyone, at least in this room, understands that. The decision to pursue DBS is very individualized per patient. Do they meet certain criteria? What's going on with the medications? Has that been optimized? Are there other problems that either would or would not make this patient a good DBS candidate? It's not a one-size-fits-all, and the data and jury are very much still out on whether doing it earlier is a better idea than doing it later. So it's certainly something to keep an eye on, but this isn't definitive yet. Okay, so other surgical options. So I mentioned before the intestinal gel. So the brand name for this is Duopa. It's a carbidopa-levodopa intestinal gel. Duopa is a lot easier to say than carbidopa-levodopa intestinal gel, so I'll be saying Duopa. And so this has actually been available in Europe for about 10 years. And essentially in Europe, it's been used as an alternative to DBS. Very similar patient profile, meaning patients are about 5 to 10 years into their disease. They have a lot of fluctuations in their movement, the peak dose dyskinesias, and then the wearing off. They're taking their medications frequently. They're having side effects related to the medication. Very similar symptom profile to DBS patients. But the good thing about Duopa is that in patients where there's a lot of cognitive impairment, this is potentially a better option than the DBS, because you can imagine when you do DBS, you're getting the electrodes down to the area that you want. But guess what you're doing in order to get down to the areas that you want to get to? You're going through areas you don't want to damage. And there's very clear data that by the approach that you take, and there's no way around it, you're doing some amount of damage, and there's an impact on thinking. And in certain targets in the brain, it also looks like that can, in and of itself, when you stimulate those targets, cause problems in thinking. So we tend, not always, but we tend to shy away from using DBS in patients where there's a lot of cognitive impairment because we know it could get worse. Not that it will, but it could. And those patients, at least in Europe, a number of them, not all of them, end up being candidates for this instead. And the reason is, this is a pump that you wear, and you can see it over here on this side. Let me just walk over here. So what this is actually a cassette where the medication is. This is a gel medication that's in a packet that sits inside this cassette. The cassette is hooked up to this pump, and this pump is connected to a tube that then goes up and through the skin into the stomach, that gets snaked down right into the part of the intestine that takes up both the carbidopa, levodopa. And so the tube is initially placed by a GI doctor, a gastroenterologist. So it's a surgical procedure. It's not brain surgery, but it's still a surgical procedure. And so there are always problems associated with that potentially. But you're not going into the brain. So obviously you're not doing any direct damage to the anatomy of the brain. And so this then gives a very steady level of medication. So instead of taking a pill where the level goes up and then goes down, although hopefully that RightRe that I mentioned may minimize some of that problem, it doesn't solve it. This clearly gives a very steady level. As long as you have the pump and the medication on, you have a very steady level of levodopa. And so what does that do? It helps minimize the fluctuations, the peak dose dyskinesias, and then the wearing off, that roller coaster ride that many advanced patients with Parkinson's end up experiencing. This does a good job of minimizing that. And so the nice thing about this is it's now FDA approved in the United States, and the specific approval is in advanced Parkinson's disease with troublesome wearing off and dyskinesias. And the key word there is troublesome. You don't want to do this just because you're not having as great a response to carbidopa and levodopa as you did when you were younger or had less duration of disease. This is a surgical procedure. It has potential problems associated with anything that you put into the gut. It can move, it can get dislodged, you can have problems associated with it. They're usually minor, but they're there. And so it's not something that we jump to just because the medication isn't working quite as well. It's really, which is why the FDA has approved it for this specific circumstance, which by the way is the same as it is for DBS, is that in these patients where there's troublesome wearing off, troublesome dyskinesia, where the patients are taking the medication frequently, this is a better alternative for that. And we'll see. We're going to have our first patient probably go through this within the next 2 to 4 weeks in town. It's been used in clinical trials already. There are folks out there running around with, literally running around with it. So it's a pump that you wear on a belt. People have gotten very inventive in the clinical trials for this. There was one woman, I was involved in these clinical trials during my fellowship, where she had stitched her own sports bra and put this pump, which is about this big. She managed to fit it into her, so you couldn't even tell that it was on her person unless she went to to the bikini and you could see it obviously. So you can get very clever with how you hide this. And that brings up another point in that it's instrumentation. Just like DBS it's attached to a battery that sits in the chest, this is a pump. It's always there. There's always a tube hanging out of your skin of your stomach. So there's a lot of pros and cons that go into any of these types of options, but it's nice to have more options now. We'll see how this goes. Again, the clinical trials have been excellent with this medication. How that translates into the real world still remains to be seen, at least in the United States, although we have a lot of data from Europe to rely on. Okay, so now we'll switch to the provider option. So we've gone through the medications you can take by mouth, we've drilled holes in your brain, we've put a hole in your stomach, and now we'll talk about some of the providers. So we've just hired, I'm very pleased to announce a new faculty member to join me. His name is Brent Blewett. He's fellowship trained in Parkinson's and movement disorders just like I am. And he was trained in this at UCSD with a world-renowned leader in the field by the name of Irene Litvan, who runs their program. She's very respected and very good and speaks very highly of him, as we all did when he interviewed. He, in addition to being a Parkinson's and movement disorder specialist, has advanced training in botulinum toxin injections, Botox. This is not cosmetic Botox, so don't call asking for the facelift associated with Dr. Blewett. This is for a problem that can be very severe called cervical dystonia or other types of dystonia, abnormal muscle contraction that can be seen in Parkinson patients, particularly atypical Parkinson's, but also can occur on its own. And he has a lot of experience and skill in that, is really going to build that component here. That's going to be one of his main areas of emphasis. So we're very excited to have him. He's going to start toward the end of July, so he'll probably start seeing patients in August. So you'll see him around in clinic. Erin Ellis, so she's a new nurse practitioner that we hired. She has about over 20 years of experience in treating patients in general throughout her career. She's very mature and very skilled. And we'll start seeing established patients similar to how Mary Gauthier, our current nurse practitioner, does. And they'll both be responsible for helping seeing our established patients, always in concert with Dr. Blewett and myself, and will form a part of the continuum of our team approach to care for patients chronically. And then Jen Guidry, a number of you may have already interacted with her on the phone. She's a relatively new nurse. She just hired, new to us. She was hired about 4 months ago. She had over 5 years of ER and trauma unit experience, including being charge nurse of the trauma unit. So she's very good at dealing with difficult situations and acute situations, and has been able to translate that into care of Parkinson and other movement disorder patients very well. She's going to be the one coordinating our Duopa program, the carbidopa, levodopa intestinal gel, and also our multiple system atrophy and Huntington's disease comprehensive clinic. She's taken on quite a bit of stuff. She's very detail-oriented and is very efficient, which is great for programs like this. So you'll be hearing her and hopefully seeing her more. The goal is, we've also hired a number of other staff, not just for the movement disorders program, but to improve our response times on answering phone calls, answering MyChart messages, getting the referral set up. We've hired a whole bunch of folks with regard to that, and that's going to free Jennifer up to do more in the clinic, and more education, more troubleshooting in the clinic, so you're actually going to be seeing her more and more rather than just hearing her on the phone. And then we're going to be hiring yet another Parkinson's and movement disorder nurse, probably also to start in July. That position is now posted, so we're going to be expanding our ability to, again, improve our efficiencies in helping our patients with Parkinson's and other movement disorders. And then research options. So the Elaine Wynn Foundation gave us significant support to develop. Yeah, go ahead.
I'm sorry, but do we have our choice in those individuals that, are they assigned to us, or do we have our choice in choosing who we want to?
So we're in Vegas, so it's a roulette. We have a little wheel. No, so you'll see whoever you see first, meaning either myself as a new patient or Dr. Blewett as a new patient. You will then see either Mary or Aaron as the nurse practitioner as a follow-up patient, and will continue with that nurse practitioner and with that physician guiding your care. So once you get plugged in, you'll stay with the same patients throughout the duration of your care.
Thank you.
Yep.
And the other fellow, Blewett, is a DO,
Uh-huh.
not an MD?
Right, so they have to go through all the same training and all the same stuff that MDs do, and they have to go through all the same board certification. The only difference is he can do some osteopathy that I can't do, so he's actually a better version of me.
But is he cute?
What's that?
Is he as cute as you?
He's got Botox, so he looks a whole lot better than I do. All right, so back to the research. So Elaine Wynn Foundation gave us some significant support that I'm very excited about to pursue. So one of the main problems we have in Parkinson's is our difficulty in diagnosing Parkinson's. Even when it seems very, very obvious, still today the only way to know 100% that someone has what we say is Parkinson's disease is at autopsy, which is a really bad way of confirming a diagnosis. So what can you do about it? Well, one thing that we're thinking about doing is to try to use MRI in a way that hasn't been used before to allow us to look at the brain structure, the brain function, and the blood flow in the brain, all of which carry a lot of information about, potentially, about what Parkinson's is doing to the brain. And the question is, can we use that to our advantage to better diagnose patients early on, to track their disease progression, and to better understand why they're having the problems that they're having? We don't have a way of looking in an individual Parkinson patient's brain and saying, okay, you're having this problem, that's causing this symptom, and therefore we should do this about it. It's a lot of science, but a lot of art in dealing with patients in the clinic, and that's okay because it's what we have, but it's not good enough. And so we're going to look at that and see if we can improve that. In addition, we're going to be doing an interesting approach to trying to understand, particularly with movement and thinking in Parkinson's, how can we use understanding the functional aspect of MRI to better understand what's going on in the networks in the Parkinson brain. So what we're going to be doing is having patients just watch very specific types of videos that we've highly annotated so we know exactly what's going on in the video, correlate that with what's going on in the patient's brain as they're watching. It turns out if you watch something, the same networks in your brain that are involved in movement and thinking are activated as if you were actually doing something to a great degree. And so the question becomes, can this be a good way to better understand and do intelligent research in Parkinson's to see what network problems are occurring in the brain, and therefore, again, what can we do about it? And then the third piece is going to be directed by our head of neuropsychology here, Dr. Sarah Banks, who is interested in cognitive exercise, so to speak, techniques that can potentially improve, particularly the mild cognitive impairment that goes along with many Parkinson patients. And the interesting thing about Parkinson's cognitive impairment is that, at least early on, most of it is related to what's called executive dysfunction. So in Alzheimer's, cognitive impairment usually is involved with memory. It's really hard to do any training with the brain when there's so many problems with the fundamental process of memory. Executive dysfunction doesn't have a problem as much with memory. It has a problem with sequencing, setting up a set of tasks, executing those tasks, multitasking, and those are things you can actually typically do a fair amount with. But how to best do it, what's going on in the brain when you do it, is all poorly understood. So that's a third part of the research that we're going to be doing with the Elaine Wynn Foundation grant money. And then in addition, when Dr. Blewett is here in particular, we're going to be able to have enough manpower to expand our Parkinson's and other clinical trials, including the dystonia clinical trials. So he's going to be an integral part of that and has specialized training in addition on the clinical trial side. So we're going to be able to have a lot more research options in addition to the provider and the medication and therapeutic options that I mentioned before. And that's all I had today, so if you guys have any questions, please let me know.
Is there a zonal range in the brain for any one function? Does it translate from patient to patient to always be in the same spot?
Yeah.
Or is there some degree of difference from one patient to another so that it would be difficult to translate precision of the MRI measurements?
So the question is essentially, is every Parkinsonian brain the same? And can you have a reliability if you know that this part of the brain is abnormal in this patient, it's probably going to be abnormal in another Parkinson's patient? The answer is that's poorly understood. That's one of the reasons that we're pursuing this approach, because what this will allow us to do is look at whole groups of patients to see where there are trends in Parkinson's in certain brain regions with regard to structure, function, and blood flow, but at the same time preserve the individual patient. And that's really where the interest is from my standpoint. So in clinical trials right now, if you have a medication that shows promise and you're giving it to a Parkinson patient, the only thing you're really relying on to know what it's doing is how the Parkinson patient does clinically, meaning how do they look? Is their tremor better? Is their slowness better? And that's important, of course, but how that's occurring is very poorly understood. And on top of that, Parkinson's, we know, is very heterogeneous. It's heterogeneous at the clinical level, how patients present. 20% of Parkinson patients never have tremor. Parkinson patients with tremor tend to have less in the way of cognitive impairment. And if you look at Parkinson brains at autopsy, there's a tremendous heterogeneity in what areas have this abnormal protein, this synuclein. And so how do you capture that heterogeneity, but at the same time see trends throughout the disease? Because there are similarities. And that's one of the reasons we designed this experiment this way, because the answer to your question simply isn't known. Hopefully this will start to tell us these are trends, these are areas that are always involved, or these are networks that are always involved, but at the same time, in your Parkinson's, this is what's different, which is why you look different than the trends. Whether we achieve that goal remains to be seen, but that's part of the reason we designed this experiment this way. Yeah?
Question. What if you have an unusual situation where you have someone who's under age 25 when their brain is still developing to maturity, and they're starting to be afflicted with this kind of disease?
Yeah, so it's a good question. So there is what's called young onset Parkinson's disease. Typically those are patients that start to develop symptoms around the age of 30 or a bit younger. The youngest I think that's been identified ever was 11. It's very rare, but it can occur. So it's an important question, and the best estimates are that somewhere in the neighborhood of 6 to 10% of all Parkinson patients started to have symptoms before the age of 40. And so it's a big deal to be able to capture what's going on in those patients well early on. We don't have a great way of doing that, again, beyond seeing them in clinic and looking for the classic symptoms. But that's one of the reasons that we want to look at this and see what's different about those patients, including the fact that they're at a very different time in their brain development than someone at 65 who starts to develop Parkinson's symptoms. So the jury's still out on whether we'll be able to see what we think we'll see there.
Thank you. And hereditary? Hereditary?
Mm-hmm.
Is it hereditary?
Right, so the question is Parkinson's hereditary? Very, very small numbers of patients are truly hereditary. So in clinical terms, when we say hereditary, we mean there's a very clear pattern of inheritance throughout multiple generations of the family. That's less than probably about 0.5% of all Parkinson's disease patients. But there are a lot of genetic modifiers, meaning if you have X, Y, and Z gene mutation, you have an increased risk versus the general population, or a decreased risk versus the general population. And that's still genetics, but it's not hereditary. But you can pass those mutations on, and therefore your offspring will be at increased or decreased risk for developing Parkinson's. But those are fairly mild modifiers. Overall, the increase for any one of them is relatively small, with the exception of one which is very well known called LRRK2, LRRK2. If you have that, you have about a 30% chance of developing Parkinson's, and that can be passed on.
Does that have anything to do with familial tremor?
Very different. So good question. Familial tremor, or what is often called essential tremor, is a completely different disease than Parkinson's disease. It doesn't look like it's primarily a neurodegenerative disease where there's accumulating damage to the nervous system like there is in Parkinson's. But it does look very genetic. So essential tremor often, unlike Parkinson's, where it's infrequent that you see it pass in families, essential tremor often passes in families. And there was actually a very interesting study done in England looking at bulldogs, because some of the bulldogs started to develop a head tremor that looked for all the world just like the head tremor that we commonly see in essential tremor patients. And because in England they have such a great pedigree of where the dogs have come from, they actually use that information to focus in on a certain area on a chromosome, and that's actively being explored to see if there are certain gene mutations there that are really driving the essential tremor that we see in humans, but that's not clear yet.
Has there been any research with tagging ligands to the abnormal protein as we did in Alzheimer's?
Yeah, so the question is there a ligand, something that binds to the abnormal protein that you can then see in a scanning? And so it's a very active area of research now. It's been really hard to get at. Unlike in Alzheimer's, where the amyloid and the tau were relatively easy to get to, meaning if you inject something into the blood or if you take something by mouth, and you have to get it through what's called the blood-brain barrier, and then you have to get it to the area that you want, and it has to bind to what you want it to and do so in a stable fashion that you can then image. That's proven to be very difficult for synuclein for a variety of reasons. Synuclein is a very sticky protein, and so it starts to glom onto itself and to other proteins. And then in addition, it's either inside of cells or outside of cells, or oftentimes both. And so the specificity along with the sensitivity has been difficult in addition to the physics. That should be solved sooner than later, but it's so hard to put a number on that just because there's so many variables. But the goal is that's only going to give you a picture of the pathology. It doesn't tell you what's going on with all the other stuff in Parkinson's. So it's going to be critical to have that, but we're also going to need the other stuff, hopefully, to add into that. And that's something that we'll probably do, hopefully in the next 12 to 24 months, is to do a combination of PET scanning with MRI scanning. So PET scanning, positron emission tomography, PET scan, it allows you to look at other measures that MRI doesn't always do a great job at looking at. And if you can combine those two, then you can really look at pretty much everything that the brain can do. And that's probably where the ligand is going to be developed. There are some that are trying to be developed that are MRR compatible and sensitive, but we'll see where that race ends up going first.
Dr. Walsh, can you see if the remote sites have any questions?
Do the remote sites have any questions?
I think they turned it off.
They may have turned off the sound, yeah. Okay.
I mean,
Yeah, go ahead.
Is it possible as a Parkinson's patient who doesn't have tremors to go through life and never come up with tremor?
Absolutely. So tremor, even in patients where that's the first and most obvious symptom, often it burns out, so to speak, later in the course of the disease. It becomes less of a problem over time for reasons that are poorly understood. And then there are patients that simply never have tremor ever as part of their Parkinson's disease. And then there are patients that are in between. They didn't have it initially, they may develop some later. But usually if tremor is going to be a significant part of a specific individual's Parkinson's, you see it pretty early on.
Are you still using DAT scans?
Yep. So the question is, are we using DAT scans? DAT scans stands for dopamine transporter scan, DAT scan. And what that does is it looks at the level of the dopamine transporter in the brain. The dopamine transporter lives on cells in the brain that are important for the brain dopamine system. And so if you lose those cells, as you do in Parkinson's, there's less of the dopamine transporter, and therefore when you do a scan looking at it, you see less of it. So it gives you a secondary indication that someone has a problem with their brain dopamine system. It still doesn't make the diagnosis of Parkinson's disease, but it does tell you that there's accumulating damage to the brain dopamine system. And sure, we use it very frequently.
Are you doing any atypical studies now?
Atypical Parkinson's, not now. So with MSA, we hope to do that soon. The problem is that there's a lot that tends to go into atypical Parkinson's studies that we're not always able to do here because we're a freestanding outpatient clinic. A lot of times there are inpatient components that are required, hospitalization that's required, And some of the medications are fairly aggressive that are being attempted, which makes sense because they tend to be very aggressive diseases, more so than Parkinson's. But we'll have to see how that plays out over time. There are a couple of studies that we're interested in that are being done now that we may end up being sites for, but we'll have to see, both in MSA as well as in progressive supranuclear palsy, or PSP, but we'll have to see.
I know your new doctor specialized in atypical
The particular one that he really specializes in is PSP. So the person with whom he worked closely during fellowship, that's really what she's contributed to greatly in the field, is the understanding of PSP. And so he has quite a bit of experience and in really a lot of interest in that. So that's another piece that we hope to grow. So we have, we see all of them, of course, but to grow programmatically around that disease in a way that we haven't done before. Absolutely, he's interested in doing that. Yep.
Is pharmacodynamic genetic profiling used to basically determine dosage for some of the drugs you mentioned? And then is it an option also to basically give a patient a P450 antagonist to try to slow down metabolism instead of the more aggressive interventions to do the same purpose?
Yeah. So the question is there a way to use an understanding of someone's genetic mutations that may make them rapidly or poorly metabolize a medication that can therefore impact how that medication works? And there's a lot of interest in that now. There have been a few different mutations that have clearly been identified to impact metabolism, particularly of levodopa as well, but it doesn't have any real clinical utility, just because the medications that are, as they are currently available, are such sledgehammers when it comes to that level of specificity of metabolic action that it tends not to make any difference. Now, I don't know that there's any P450. So P450 is very important in the metabolism of a lot of different drugs in the liver. And so if you can change how that's metabolized, therefore you can change how that medication is dealt with in the body. And I am not aware of any studies that have looked at that, because then that also changes the metabolism of all kinds of other medications as well, in addition to other stuff. And so I'm not aware of any studies that have looked directly at that. But there's a lot of interest in that as we get more and more individualized in the approach to the Parkinsonian patient. Are we missing opportunities where we should be screening for certain types of polymorphisms, but there's no clinical utility yet? Yep.
What can you tell us about causes of the disease and prevention?
How much time do you have? That's a whole other talk. So the simple answer is that we know that protein synuclein plays a core role in the developing of the pathology. And it seems that the earliest areas that are involved with abnormal synuclein are in the gut and in the nose cells, the nerve cells of the gut and nerve cells in the nose. Somehow that there's either environmental impact or a non-environmental impact that changes that synuclein. So it starts to aggregate. That aggregation starts to cause cells to misfunction and ultimately die. And then that abnormal synuclein gets out into the extracellular environment and can start to transport into the rest of the nervous system. That's a very gross oversimplification, but the core process that you have an initiation and then a spread of that abnormality is very clear. And so that gives you the potential to start targeting therapies early on to either stop the protein from becoming abnormal to begin with, or stop its ability to aggregate on itself and onto other proteins, or stop its ability to spread. And that's why these trials are now being done with what's called a monoclonal antibody. So this is using the immune system to develop an antibody just like you normally do to any number of viruses and any other infection that you have. Can you develop an antibody to this abnormal form of the protein, use the immune system to get rid of that abnormal form of the protein, and therefore get rid of one of the prime movers of the disease, or at least slow it? And there was just a trial done in Alzheimer's disease that shows a lot of promise for the first time in the ability of that same type of technology to work. It wasn't developed against synuclein because that's not a core component of the pathology in Alzheimer's, but the same logic applies. And it looks like that there's reason to be hopeful that that could be successful. So that's now being started in Europe with synuclein and in MSA, in addition to Parkinson's disease. There are not a lot of sites in the United States right now, and there probably won't be in the near future. It's very early stage of these clinical trials, mostly designed to see, are these things safe? You can imagine when you have the immune system getting rid of that protein, it may also get rid of a lot of other stuff that you don't want to. And that is a problem, actually, even in this recent trial and in other trials that were done in Alzheimer's with antibodies. You get a lot of immune response. And when you have immune response, just like when you cut yourself, you get inflammation, you get swelling. Same thing happens in the brain. And you don't want to swell in an area that can't expand, which the skull prevents you from doing, and it can be fatal. So there are things that need to be worked out, but the basic concept of that technology and the basic ability to get to that technology is real. And that's one of the things that's so exciting. And unlike in Alzheimer's, where we don't have a lot of great medications to use that can really improve symptoms, we do in Parkinson's. So if you could stop Parkinson's or at least significantly slow it early on, we got a lot of stuff we can throw at it to improve the symptoms, probably for the duration of the disease, without even curing it, especially if you can get at it when it's still sitting in the nose or in the gut or in other parts of the brain and hasn't gotten to too much of the movement area. So there's a lot of reason to be hopeful, but how that will ultimately translate into reality, that's not clear yet.
Was it you, Dr. Walsh, last year that told us the 4 symptoms with the smell, the problems with smell, constipation, depression, and sleep?
That's right. I have all of them myself right now. My wife is out of town, and I have an 8, 2, and 1-year-old, so please forgive me. Yes, that is the case. And so if you look at patients that have significant loss of smell, significant constipation, significant mood disorder, depression or anxiety, and also have the significance of REM sleep disorder, rapid eye movement sleep disorder. Those patients are at much increased risk versus the general population of going on to develop some type of Parkinson's. It could be typical or it could be atypical, and that's the problem, is who's going to get what. So that part isn't clear yet, but that's the importance of understanding the pathology early on, because if you can do that and then you develop in the future some ability to stop progression or slow it, you want to get it in as early as possible, but you have to do it as reliably as possible. So that's why we need some type of scan that says this is absolutely what's going on. We know that this is going to happen, and therefore we need to give this to somebody. But they're not benign agents. They have the potential for lots of side effects. And how long do you have to give it? Over what period of time? Will they develop more side effects over time? So you need to be really confident in the diagnosis, much more than we are now. And so that's one of the reasons that there's so much emphasis, not only on the therapeutic side, but on the diagnostic side, because you need both in order to work well with each other.
Do you feel the same way about the vaccine study that we've just recently read about as you do about the antibiotic therapy?
It's the same concept. So what does a vaccine do? It makes the immune system develop antibodies against what it is you're vaccinating against. So it's the same exact idea. Can you use the immune system to recognize that abnormal protein and as selectively as possible get rid of that abnormal protein, but not at the expense of damaging other areas. So that there are a lot of ways to potentially do that. You could develop the antibody yourself in a tissue or in a petri dish, which is the way the one that was most recently done in Alzheimer's essentially was done, or you could vaccinate someone and let their own immune system there are a lot of ways to get at that, and how much one is going to work better than the other is not well
It
understood.
doesn't seem like they're getting at the root cause, though. You've still got whatever caused it.
Well, and that becomes the question, is why did this start to begin with? But that really becomes a moot point if you can stop it. So it's still interesting and still warrants exploration, but boy, if you can stop or slow the progression, who cares how you get it? And most likely it's going to be multiple pathways. It looks like there are a lot of different ways that you can get to abnormal synuclein. And you're probably not going to be able to prevent against all those different ways. But if you're able to stop the abnormal synuclein from doing its damage, it doesn't really matter how you get there. And hopefully that will be the case.
Is there any promising stem cell research?
Yeah, so it's a common question. Right now, nothing that's remotely close to ready for prime time. So stem cells have been looked at for a long time in Parkinson's, over 20 years. And there are several problems with it. One is that stem cells are not smart. They can do a lot of stuff, but they're not smart at what they do. And so you don't want that in the brain. You want something that knows what it's supposed to do and does it very well and integrates into the rest of its environment very well. And that ends up being very hard to engineer that. On top of that, when you put stem cells in, it's clear now that those patients that had that done who ended up passing away and went on to autopsy, they had the same pathology, the same abnormal synuclein pathology in the stem cells as they did in the non-stem cells in the brain. So somehow that abnormal synuclein was able to get into the stem cells and cause the same damage. So it's not a cure. So now you have to engineer the cells to be the right type of cells, make the right type of proteins, fire the right way in the brain and integrate with the brain the right way, and somehow engineer them so that they don't let the synuclein in. So it's certainly warrants investigation, and there are some very good labs looking at it, but it's highly theoretical at this point. Sure. Any other questions there outside of Vegas?
No, thank you, Dr. Walsh. We enjoyed you as always.
Okay. Great. No more questions here? Okay. Oh, one more.
I have a question here. I represent the National Cannabinoid Research Institute based in Colorado. We've been in communications with Dr. Jeffrey Cummings on potentially using cannabinoids as a research option. How can we integrate that as a research option to what we have said today?
Yeah, so the question is, can we integrate cannabinoid research into Parkinson's disease research? And to clarify, cannabinoids are, many of you may know of them as independent agents. Many of you may know of them from marijuana, which is tetrahydrocannabinoid is one of the main psychoactive ingredients in marijuana. And there's been a lot of recent interest in cannabinoids. There are a couple of different receptors in the brain, cannabinoid receptors 1 and 2 in particular, that are expressed in an interesting way in the brain, meaning that they are in areas of the brain that anatomically may be interesting when it comes to movement problems like Parkinson's disease. The problem is that there's really not a lot of great understanding of what those receptors are and are not doing. Therefore, there's not a lot of understanding about what should or shouldn't be done with the ability to either increase cannabinoid receptor activation or block cannabinoid receptors or some combination thereof. So that research is really kind of in its infancy. It certainly warrants further exploration, but one has to be very mindful of it. In particular, those receptors are not only in movement areas, are also in thinking areas. And thinking is a big problem in Parkinson's as the disease progresses in a number of patients. And we don't want to be in the position where we're causing undue problems with a symptom for a reason that we don't understand. So it certainly warrants more exploration, and there are some good labs looking at what are these receptors doing in their basic function, and hopefully as that science matures, we can then start asking intelligent questions about what could they be doing in Parkinsonian patients. But I think it's probably a little early for that yet.